Afternoon, everybody. Thank you for joining us today. I'm sure that a few more people will sort of join over the coming minutes and things, but we'll make a start for today. So the event is being recorded for those who either want to watch back or have not been able to make it today. So this is a second of a series of events that we are running about maternity quality improvement. So we do continue to have a really good interest and an uptake, which shows that there is a want and a need to link up more and to learn and share from our quality improvement efforts across maternity. So my name's Kirsty Hartwell and I'm the Quality Improvement Lead at Warwick Hospital in the Midlands, and I'm going to be your host for today, along with a team of fabulous speakers and facilitators, which we wouldn't be here without. So while we're waiting for people to join, please feel free to put in the chat who you are, where you work, and you might see somebody that you know pop up, so feel free to give them a little wave, or you might also see people pop up in areas that you might want to link up or connect with as well. So through the course of the afternoon, do feel free to tweet about today's event, share your ideas or thoughts of your own or your quality improvement projects that you might be running in maternity, and you can follow other people's work as well. I'm also going to launch a poll just to see where people are based across the country. This will just pop up on your screen shortly. We were seeing a lot of people registering from different parts of the country, different hospitals and organisations. So I'm hopeful that we've managed to capture a wide area of people. And if not, we can use this information to know where people maybe need to know more or share information and communication about our future events and updates. So I wanted to get a bit of an overview, an update to where we currently are and where we plan to go. So our first event focused on how we can better understand who your stakeholders are and utilising those stakeholder analysis and matrix tools to understand what power and impact the people in our organisations have in relation to our improvement work. So we worked with you to gain an understanding of who you felt should be involved and supported to have more influence or power than they currently hold, looking at sharing and learning from quality improvement. And this is the outcome of the insight and the work that we did back in June. And we've used this information subsequently to ensure that those people and groups are communicated with and can be involved. So if you weren't there, you can join and look at any of the past events in our Futures platform. So the recording is saved in there, and we'll pop a link in the chat now for you so that you can refer back to that and join that if you want. Thank you, Susie. And hi, everybody who's joining. So at today's event, we're going to focus more about understanding the problem. So this is the vital step that really deserves some time taken to work out the question of what are you actually trying to solve, and are you trying to solve the right problem? So it consists of asking a series of questions and using answers to create a thorough problem statement. To solve those problems effectively, you need to form a complete understanding of them first. And this means going beyond the surface of symptoms and identifying the root causes, the underlying assumptions, the relevant factors, and the desired outcomes from this. And then through that series of events, we will move through the processes, learning as we go and sharing some great presentations where we can all learn from the quality improvement work that they have done. So before we get started, I wanted you to have a think about your preference for how you have your cream tea. I do quite like a cream tea. So in the poll, feel free to answer of the options on the screen there, how you might prefer to have that. So number one is the Cornwall way. So you've got your jam on the bottom, your cream on the top. Number two is the Devon way. So you've got it the opposite way round. And then you've got number three, for those who really don't mind how they have a cream tea. And to be honest, I enjoy jam, scones and cream, so I'll take a number 3 for me. And we've got quite a mix coming up there. Oh, and somebody's from Cornwall and likes a 2. So would you go for option number 4? So it doesn't quite look as appetizing as the others, I do admit. But when we come to think about an outcome that happens in maternity, it might be a patient safety incident or not, maybe just something that we didn't expect to happen. How many times will you think or talk to your team and think, how on earth did we end up with that? But workers can only do so much. Any process has the built capacity and capability to determine by the way that it was set up. So let's think of the Great British Bake Off, which is out of the moment if you're not watching it. So for those that are not familiar with it, all of the bakers have a technical challenge. They all have the same instructions, they have the same work environment, they have the same equipment, but there's varying degrees of results. So when you're looking at your problem, you can look to the root cause to understand more about how this outcome was achieved, or not, in the case of my cream tea that you can see there. So I was clearly missing out on the important steps that might result in not having opened the jars in the first place. So my steps just didn't include unscrew the lid of the jar. But real improvement comes from the underlying way a process is set up, and the aim is to design out the error. So remembering that we do have human factors, ensuring that we have a culture of psychological safety within our teams so that we can try and foster the enabled people to speak up so they can identify when they might have problems that are pertinent to the improvements that you're working on. So obviously this will just give you a little bit of a flavour of what we're going to go through today. And you might have a bit of a hankering for a cream tea after this. But we're going to hand over soon to our first presenter. We got Heather and Michaela, who are from the quality improvement team at the Royal Cornwall Hospitals. And they're going to expand far more on my introductory piece to provide a teaching session on how to understand the problems and the tools that you can utilise within your work. We'll be following this up with some breakout rooms to work on and practice some of the tools that you can then apply in your own work. And then lastly, we've got Louisa Davidson, who's the Associate Director of Nursing and Midwifery and the Head of Midwifery at Birmingham Women's Hospital. And she's going to be sharing the work that they've been doing on the last couple of years with the induction of labour process. So I do hope that you enjoy the event and you do get some really good value out of it. And I've got the pleasure of passing you over to Heather.
Good afternoon, everyone. I'm Heather and my colleague Michaela is here as well, here to talk to you about understanding the problem. I think Kirsty is going to spring a poll on you in just a moment to just get a feel for how confident you are with the process of understanding the problem at the moment, just so that we can then have a feel for what you feel like at the end. So if you can just click the pretty little stars that seem to hopefully have appeared on your screens, that would be lovely. Kirsty, if you could just give me a nod when you're ready to move on. Yep, all good. Okay, so I will leave you filling your stars in and magically, hopefully, share the right bit of my screen and then find my notes. So I've got Michaela looking after the chat for me. As we go through this, if you've got questions as we go along, I'd really rather you shout it out, shove it in the chat, put your hand up, whatever, as we go through, rather than holding them till the end, because it might prompt some other people as we go. So, as Kirsty said, I'm Heather. My colleague Michaela and I are from the QI team at the Royal Cornwall Hospital Trust, and we're here to look at the starting point for any of your QI projects and understanding the problem. We're going to give you a kind of talk through why it's really important to understand the problem that you're tackling. We'll look at a few techniques that can help, and then, as Kirsty said, you've got some breakout room time to get your teeth into it and actually give it a go. So this is the 6 steps for QI that we use in RCHT. And as you can see, number 1, discuss and understand the problem, issue or opportunity. Because I think a lot of the time we focus on it being a problem, but actually it's an opportunity for improvement. And it's really important that we're not putting always such a negative kind of, oh, it's a problem, we need to deal with it. Actually, it's an opportunity to improve. And that sometimes changes the mindset of the way people approach QI, particularly when you're trying to engage other people in your project. And also it's important to remember that it's not your understanding of the problem. It's the understanding from your wider stakeholders and their take on that problem to make sure that you've got everybody's opinion and thoughts on how this kind of all fits together, because what you consider a problem actually might work really well for somebody else, and it's really important to get that kind of balanced view on it. And the whole point of QI is to stop you jumping to those solutions and those assumptions to make sure you've got that really balanced picture before you jump in. So we're going to look at a few bits and pieces that can help you out. So some of the tools that you can use listed on the screen there: clinical audit, consultation and collaboration, 5 whys and fishbone, which Kirsty's mentioned already, and some mapping systems. Loads of different ways different tools that you can use, different ways you can use them. A number of them pop up at different points through your QI process, so you might well find in future sessions that these same things come around again. So particularly clinical audit can come up at various points. So it's a clinical audit as a starting point. It's really useful at actually identifying the problems, which you can then work to understand. So hands up now, I'm not clinical, never worked in a clinical environment, but so clinical audit, from my understanding of it, is aiming to improving patient care by reviewing clinical performance against some explicit standards and letting us target our improvement activities to areas where we're not performing as well as we could. So there's national clinical audit programs, but also I imagine there's bits and pieces going on within your own trusts. And it's using the information that comes out of those clinical audits to pinpoint some particular things that you might be able to target with your project to work on those improvement activities. Consultation and collaboration. And I know we quite often go with the too many cooks spoiling the broth and all that, but actually it's really important to make sure that you're looking at your problem or your opportunity from everybody else's perspective as well, making sure you get those different views on it. So because your process, your clinical pathway, whatever, is going to touch so many different groups of stakeholders, it's really important to make sure that you're looking at that from all of the different angles. So learning from others, listening. I think that second point on that, the picture you've got in front of you there, that learn to listen and not to respond, is really information gathering so that you can best understand how other people are perceiving all of that. And again, this is not just for your understanding the problem phase. When you come around to your sort of plan, do, study, act, PDSA type cycles, you can use that consultation and collaboration throughout that. That's really important to get those different perspectives, whether that's patients, whether that's staff, whether that's other organisations that process interacts with. Really, really important to talk to all of those people. So the 5 whys. It's a technique that we can use to drill down into a problem rather than take an action around a symptom. But it is quite important not to sound like a toddler. So for those of you with small people at home, why? And sometimes you just lose it. But actually, it's a really useful tool because it does help you walk through that process. So the one you've got on the screen in front of you there, why has the photocopier stopped? A fault occurred. Why has the fault occurred? Paper was jammed. Why is the paper jammed? Was stuck in the compartment. Why has it got stuck? The paper was damaged. Why did the paper get damaged? The box was dropped. So actually now you've got to the point where you're not, actually it's not fault with the photocopier. The box got dropped, so the paper got damaged, and then it got stuck in the photocopier. So it kind of gets you through right down to a bit that you can then start investigating. And we say 5 whys, that tends to get you more or less there. Sometimes it might be 6 or 7 whys if it's a particularly gnarly problem. But it is just an interesting way to walk yourself and challenge your own thinking, because I think a lot of us, when we know that system and we know that process, we can't pick it apart so easily in our heads to actually get to the real number of the problem. Because for my personal view, I think we need a sixth why on there. Why was the box dropped? Sometimes it was just an accident, but maybe the shelf wasn't maintained properly. Maybe the delivery driver wasn't so careful. There's an awful lot of value that you can get out of those sort of 5 whys technique. And it might feel really simple, but actually when you use it in reality on some of those real problems, you can actually get some quite interesting insights that you wouldn't have thought were even there as part of that problem that you're looking to understand. So the fishbone tool, this is a different way of trying to look at your problem. It's a cause and effect analysis, really. So you're looking at a whole load of different aspects that might impact your problem. So it's the underlying factors, the contributory or causal factors, not just the symptoms that is producing. And this tool can be used to capture and summarise the causes and help you to fully understand and identify all of them and display them on one page. So pop the problem or the issue on the far side, so the circle side of this side, so the opposite end of the aim, for example, and come up with the categories of potential causes. On this one, we've got equipment, process, people, materials, environment, management. So those are the kind of standard ones, if you like, that come with the fishbone, but don't be afraid to change those if actually you're finding a lot of things that don't quite fit within those categories. And you can add primary causes, but some of those primary causes might have secondary influences as well. So what I've got on the next slide is a bit of an example here. So looking at waiting times and the different sort of impacts on those waiting times. So wheelchairs unavailable, lifts broken, and then the secondary factor to your lifts broken is the poor maintenance. Not enough treatment rooms, small inner city premises. So there's an awful lot of things that you can unpick through that. And like I said before, you might find that you need some extra ones of the fish bones to categorise all of your improvement. And again, you can use that why question in here. So when you're looking at the process takes too long, why does the process take too long? A lack of automation. So you can use almost the 5 whys to inform your fishbone tool as well. Michaela, is there anything else that you've just skipped through that and realised that I just need to double check that I haven't missed anything from your perspective with using it?
No, I don't think so. I think another common one that isn't on your diagrams, I don't think, is finance and cost, because I think that comes into quite a lot of them. So just another one to think about when you're looking at the fishbone. But no, apart from that, all good.
Thank you. So I've got what have we got on this one? Ooh, so this is our pretty coloured one that we use at RCHT. So this one is a real life example from one of our projects that we did. I think it kicked in during COVID, and we were having the volunteers at the hospital were looking at calling some of our patients who were discharged just to check in on them after they've been discharged, to check they're all okay, really. So, but we weren't getting much of an uptake from it from the clinical teams. We weren't having many calls being made by our volunteers. So we started looking at, so the people, not all the staff are fully engaged or committed to the project, sickness and staff shortages, measuring it, measurements not being fed back to staff. So actually they don't know what the point of this call would be. And only a handful of people have access to the measurement data. So again, if you're not spreading that improvement and telling people why it's so good, you're not going to get so much of an uptake on it. Environment, COVID-19 has impacted on the ability to communicate effectively face-to-face. So actually, how do we spread that message about this service? What is it that we potentially need to do differently? Not all staff are following the processes implemented, meaning referrals are not getting through. And not all patients being referred meet the specific criteria. So there were some criteria around that. But again, it's what is the actual problem? Is it that people don't know? Is it that people aren't following the requirements? So it just helps you pull apart those threads to work out where best to target your improvement. So those are the two that we'll be looking at in the breakout rooms. Are there any questions, queries, anything in the chat, or any hands up, Michaela, in terms of how we might go about using those? I think a lot of them do. They make a bit more sense once you start having a go at them yourself. Is there anything in the chat or anything, Michaela?
Only about having a copy of the slides, which I believe will be available afterwards.
Yeah, absolutely, definitely. So the other thing I just wanted to touch on as another way of helping to understand your problem is a bit about processes and process mapping. So it's not something we're going to be covering in the breakout rooms necessarily, but I think they're useful things to be aware of that might help you potentially in different ways to understand those problems. So what is a process? There are a series of actions or steps taken in order to achieve a particular end. They might cross departments and functions. People don't understand necessarily the whole process. They might just be focused on their bit of the process. So don't necessarily understand why you might need to change something, or my bit works fine. Why do we need to change anything? Often they're not designed, they evolve. Sometimes there's no clear owner. No one's responsible for improving the whole process, and they're not always effectively measured. So when you're trying to unpick those problems, if it is part of a process, it might be that you are working across multiple different teams, different organisations potentially, and really making sure that you are looking at that whole thing from start to finish, because what you change in your little area might have a knock-on effect either upstream or downstream of your point in that process. So it's when you're looking at processes and systems, it's important to look at it, like we said, from a lot of different angles. So we can have very different views on the same process. So as the sort of the standard operating procedure, as we expect things to happen, patient arrives in the department, they receive their treatment, they get discharged. Lovely. The staff reality of that, patients arriving, they wait for a bit, they get booked in, wait another bit, assessment, waiting, monitor, wait, treat, wait, discharge. So that again is the staff focus. So they're focusing on the process that patient goes through. And what does that actually look like to a patient? They arrive, there's a lot of waiting. Book in, wait, assess, wait, monitor, wait, treat, discharge, hurrah. But that focus is completely different to the clinical one. So as a staff member, you're looking at the steps this patient goes through. Potentially from the patient's reality, they're doing a lot of waiting for not a lot of contact time. So it's really important to understand those different ways round that system. Some other ways that you can look at your processes and your systems is a spaghetti diagram. So this is the movement around a physical space. So whether it's people, whether that's notes, whether that's equipment, how does that item move within that space? So you can see on here, this is just an example of the way you might display it. You might have your layout of your clinic area potentially, different colours representing different individuals. You could put patient notes on there or samples potentially if that's what's going on in your area. And where are they going? Are they going, is it a nice straightforward process? Are they hopping in and out of lots of different rooms? Where's the potential for making those savings, making those improvements? There we go. Right. So, and a process map, slightly different to a spaghetti diagram in that it's less about the toing and froing and more about the steps in a process. Loads of different ways to do it, but it's really powerful when you get that kind of multidisciplinary team approach to it, and get almost everybody in the same room with a whole load of post-it notes. Best sort of QI. I really enjoy that one. So not quite cream tea. Looking at making a cup of tea this time to go with your scone. Putting the kettle on, get a cup, tea bag and cup, add the water, remove the tea bag, potentially adding sugar or milk, and drink your tea. Nice and straightforward. But actually, when you start looking at it, there's a lot of little steps that come in there that add more complexity, potentially some duplication, making sure you've got all that equipment potentially set up in your area before you start saves an awful lot of toing and froing later down the line. And it's really important just to map that all out. And you can also, wearing my sustainability hat, add in some sustainability factors in here. So every trust has got a green plan, which at a minimum is aiming to meet the greener NHS targets of net zero by 2040. So thinking about where you're potentially using resources you don't need to, whether that's energy or water, whether it's travel, whether it's people's time, because that's just as important, whether that's clinician time within the environment, within your clinical environment that could be used on seeing additional patients, or whether that's actually your patient's time of waiting. Can you streamline that process to save people's time? And the financial resources and the cost as well. So as Michaela mentioned earlier, supplies, waste disposal, all of that has got a value. And it's really important to consider those kind of things when you are mapping out that problem to try and work out how to target your improvements. I won't touch too much on the next couple of slides. It's just some pointers which might be useful when you're doing that process mapping on your own. So what you might need, how you might go about it, and what kind of the questions that you want to be asking. And then a bit there for you about how you're picking those apart afterwards, and what are you looking for in that process map once you've defined your process. And it might look like something like this. And so we've done sessions on Teams with sort of shared documents online, but we've done it with post-it notes, and it's really important to, like I said, to get that multidisciplinary team involved. So anybody who might be involved in that process, really important to get them tied in. So I've actually rattled through that a lot quicker than I expected, so we get potentially even more time in your breakout rooms. So we've talked about 5 whys, fishbone diagrams, which we'll have a bash at in a minute in your groups, but also mention spaghetti diagrams and process mapping. And I'm hoping that some of you might have QI teams in your hospital who'll be able to help you with things like this. But if not, there are plenty of QI teams in neighbouring hospitals who I'm sure will be more than happy to lend any support. We can provide some templates to Kirsty that we use within our trust, so we can share those out with you as well. But if there are any comments, questions, I'm happy to take those before we dive off into breakout rooms to give them a go. Silence. I think we might be all right by the sounds of it, Kirsty.
Yeah, thank you. We'll hand over to Annie, who's going to introduce the practice element of the understanding the problem before our breakout rooms.
Okay, thank you very much both. I'm Annie Williams. I am a quality improvement programme manager at Oxford University Hospitals. I'm a midwife by background, but I work in a central trust QI team now. And we're going to go into our breakout rooms in a minute, but just to go through what we're doing. So we have, I believe, going to have 12 breakout rooms to split people into. There will be, there are some facilitators around. You may or may not have a facilitator in your room because it's going to be randomly generated. But if you don't, just see if somebody will sort of put their hand up to kind of help to nudge the group along if there is somebody who feels pretty confident with fishbone diagrams or with 5 whys, but don't worry if nobody does, just have a go anyway, and we'll do a bit of feedback afterwards. If there is, if you finish early before we bring you back into the big group, then you can either just have a chat about quality improvement in maternity, or you could sneak a peek at other people's slides and have a chat about those. It will say which breakout room you're in, and that will tell you which slide to go to. So I will in a moment put the link up to the Google Doc, and it's got 12 slides. So if your breakout, thank you, Susie. If you're in breakout room 6, then navigate to slide 6, and so on and so forth. So the question is, what problem are we actually addressing here? And so just to kind of have a minute to go through that, I'm quite a visual person. So I'm going to introduce you to an entirely mixed metaphor image now, which is of a big, big tree with lots and lots of branches. And each organisation, each kind of maternity unit is out on a limb on one of those branches. And not only that, but at the end of your limb, you are trying to reinvent the wheel quite often, because we are really, really similar across across the world probably, in maternity services, we are actually having to deal with very similar problems, particularly kind of across the UK. We are having to do very, very similar kind of improvement projects. We're working hard to deliver great care to those we serve, and yet we are kind of often in these sort of pockets, sort of doing silo working, and we don't really know necessarily what's going on elsewhere. Sometimes you're out on your limb and you're trying to create your wheel, and you've got loads of tools at your disposal, QI tools to use. Sometimes you've got a bunch of tools and you have instructions of how to use the tools. Sometimes you don't have instructions of how to use them. And sometimes you actually kind of are just trying to work on something with without any tools or really knowing what's going on elsewhere. So this is the problem that we're trying to address. We're trying to work out how is it that we can fix or improve this issue, and whether that's how we can go about doing QI, how to apply tools in maternity services, knowing what's been tested elsewhere, knowing what's been successful elsewhere, and why. It's trying to kind of work on this kind of slightly discoordinated with lots of variation in practice. So that's the problem that we are looking to try as a kind of peer-to-peer network to look at and address and work out how we can try to improve things. And 6 of the groups we've set up fishbone diagrams to try to sort of just have a chat about this problem and see if you can kind of map some of this out on the fishbone diagram. And 6 of the groups have got the 5 whys to again just have a chat and think about trying to use this tool to see if we can work out what's the root cause of this way of doing things that we're seeing, where we're reinventing the wheel in all of our separate different places. Does anybody have any questions about the breakout rooms and what it is that you're going to be doing? Okay. Right. Was there anything else, Kirsty, that I need to cover before we split people into breakout rooms?
No, that's great. Well, you're all going to be randomly allocated, so hopefully more than one of you will be able to access a link. If somebody self-designates themselves as the person who's going to document all the ideas while everybody's sort of talking, so there's not too many people working on the same slide, I'll be sat in the main room and I'll dip out into rooms. So if there's any problems with any of your rooms, then I'll be sat there to try and help with any technical issues. I'll give you a little message when we're sort of coming to a close, just to sort of keep you guys an eye on the time, and then we'll spend some time just having some chance to feedback as groups about how you found it and anything that you found with your learning. So you will find that you'll be automatically moved into your breakout rooms shortly, and we'll start the breakout sessions. Hi everybody. Welcome back to the main room. Hopefully you weren't halfway through discussions, which I think most people are when they are working in the breakout rooms. And I could see that there was a lot of typing going on with a lot of the groups. So hopefully you got to really explore yours that you got designated. And if you did have time, obviously you could have a little peek at other people's that they were using. So I'm going to put a poll back up just to sort of understand a little bit more about maybe how we've supported you in learning a little bit more about understanding the problem. So it'll be the same poll as before, but just the opposite way round to how you've got your confidence. And hopefully that's increased, so that'll come up in the poll for you. So while you're filling that out, we've got a little bit of time just to a couple of people to maybe share their experiences of using one of the tools. So there were 2 tools that were launched, which was the fishbone and the 5 whys. So out of the groups 1 to 6 that had the fishbone, would anybody like to share how their experience went with the breakout and testing that tool. Did you find it useful? Did you find anything interesting out? Was there any challenges with it? Any volunteers? Lindsay, go ahead.
So I was very lucky. I also had Heather in my group, so she kept us all going. But actually, I think initially coming at it a little bit cold was a bit tricky, so it took a moment to kind of get going with our discussions. But actually, once we'd started discussing the different things and started getting into the nitty-gritty, it almost started to self progress, and before we knew it, we'd got another bit of another arm, so to speak, another topic that we'd added in around capacity and capability. So yeah, it was a bit slow to start, but once we got going, I think we were suddenly like, oh, 20 minutes is gone, that's it. But we probably could have kept going.
Thank you. Did anybody else find that had the fishbone diagram, that they found it a little bit hard to get started, but once they started talking around the issue and problems, it started to flow? Yeah, Emma's saying yes. I think we found that in my group as well. It was a little bit quiet to start with, but then soon you start getting a lot of discussions going around that then links with multiple arms, and then you're able to fill up your sheet before you know it. So hopefully you found the fishbone really useful, and if you weren't allocated to one of the fishbones, then obviously please do have a look. Michelle, were you wanting to share with your group as well?
Yeah, it was just there was only a couple of us, so it was kind of quite a small group. But I think we were challenged to figure out whether we were looking for solutions or we were identifying the problems. So it took us a little while to kind of figure out, and actually that, you know, where we were supposed to be identifying, you know, because automatically you go to, well, we want to fix the problem and what we're going to do about it, because we know, you know, from a comms point of view, trying to get people together and things like that. But actually it was just sort of breaking down that before you kind of get to the, you know, what the possible outcomes were. So yeah, it took us a little while to get a bit of clarity on where we were headed.
Yeah, definitely. And I know that Louisa will talk about this in her presentation later, the fact that we all do naturally go to problem solving, and actually to really understand the problem is where you're going to get far more useful information to move forward and get more usable solutions from a wider range. Going back to the introduction of understanding, is this the right problem that I'm trying to solve, because I might be looking at this problem, but actually that's influenced by X, Y, and Z. Thank you. So out of the people that had the 5 Whys group, is there anybody that wanted to share anything that they had found or anything useful, or if, again, they found that it was a useful technique to try with their problem solving? You can either pop your hand up or put anything for sharing in the chat as well.
In the absence of anybody brave, shall I come in with our group?
Perfect, thank you, Zoe.
Well, I think we might have scared ourselves off with defining a wicked problem in the end, which is really interesting actually, because we weren't necessarily looking for the solutions, but it's quite a bit scary about what the solution might be. But we didn't have a chance to look at everybody else's, but I've just had a look at the next one, group 8, and they've practically got the same. So that's really interesting. So I just wondered whether anybody had any thoughts on that, because the why can often lead you to a wicked problem, and therefore how do you then build that into a quality improvement project that would have a aim and something that's measurable, that is then something going to improve the issue, when the wicked problem is actually what the last why is to do with behaviours and customs and culture.
Did anybody else find that with their 5 Whys, that they found they ended up with a big problem? Yeah.
Yes, we also went in group 10 from a problem to another, and the final one had 3 of them. Now, the idea is that we either learn how to accept things and to accept the fact that there are things that we cannot change. And then what I'm thinking now is, the serenity prayer, the one that what you can accept, you accept what you cannot change, and go to change what you can change, So I think it's a very useful tool, this several whys, and also the conversation in a group. I found it quite interesting. I don't know if you particularly could have taken any quality improvement from this conversation that we had, but I'm sure that if we sit on it, we can get to something very interesting.
Yeah, I think it's important to dedicate that time with your teams, and that's always the challenge when we're so pushed in all of our work as well. And Keely's put in there that it's always addressing what is in your circle of influence, and that is really important. What can you have an effect on, and is that something that is your responsibility, or actually do you need to be speaking to other people? Annie, did you want to share anything?
Yeah, we were also a very small group, but I really enjoyed the process of having the discussion about it. And the key thing I found was at each stage, we needed to kind of talk about what it's really like, kind of what's the reality of the situation, why is this, but then take a step back and look at, okay, but what's the real reason underneath that for what's going on? So it was kind of the practical example, and then okay, what's really going on? What's the kind of meta stuff that's going on here? And we got this kind of thing about culture and behaviours on our 3rd why, and then carried on digging down underneath it. And there was such kind of richness of discussion about it, and about the fact that everybody's focusing kind of on that sort of top down, trying to change culture and behaviours. So why is that? And it's that sort of sense of, well, actually what's missing there is the kind of grassroots people who are within the tribe, who are kind of prioritizing the grassroots improvement projects and linking up with the vision. It was really fascinating discussion. I really enjoyed doing it. But yeah, there was that kind of having to pause and really think at each stage, okay, what's really going on here? What's going on? What's the experience of people in practice, and why is that? It was great fun.
Thank you. I'm glad that you enjoyed it. So we're going to hand over to Louisa, who's going to present the work that they've been doing at Birmingham Women's Hospital on the induction of labour process. And Louisa is going to focus on what their problems were and how they looked at those problems. So over to you.
Thanks, Kirsty. I'm just going to share slides, all being well. Can you see those? Lovely, great. So yeah, so thanks, Kirsty, and apologies, some of you may have heard some of what we've been doing if you're local to us, but Kirsty asked me to come and speak today about how we understood our problem, because we have managed to make some inroads into improving induction of labour, and I'm sure I'm not alone on this call in having some concerns with induction of labour, which can be wicked in themselves. I won't stem too much around the methodology that we use, but basically we formulated it as a QI project using a lot of the tools that Heather has spoken about earlier in the session. And if I can give one tip for any of you to take away, it's to really get some good baseline data, because having good baseline data means that you do actually fully understand what's happening, whereas we often do the sort of work as done as work as imagined, don't we? And we think we know what the problem is or what the solutions are from our perspective, but actually when you dig down into that, it's not always the right solutions. It's not always what we need to do. So our journey started a few years ago. We've had some problems with induction of labour for a long time. I joined the organisation in 2019 as a consultant midwife and was asked to sort out induction. And what we were finding was we were seeing induction come through HSIB cases, which is now not HSIB anymore. So apologies, I'm a bit behind on my slides. we were having PALs and complaints around service users' experiences of going through induction. We could feel and see day in, day out that women were waiting at various points in the process for parts of their induction, or to get in for induction, or to come to delivery suite, or to get a prescription of prostaglandin. So there just seemed to be, felt like there was problems and delays in the system. And actually what we didn't know directly was, what did that all mean? So did it impact on safety and outcomes? We thought so, because it was in our HSIB cases, but were these just fluke, or was there actually a link between that? So with our, the risk of induction rates going up, I mean, ours haven't actually increased over the last few years, but it was important that we understood what our problems were. So we put a working group together, and it was really important to get the right stakeholders around the table. But what was more important was that we got the engagement of the board. And when you start talking to the board about women's experiences, it might not be particularly great, but actually doesn't really strike a chord with them. When you start talking in terms of patient safety and harm, then that's much more the language that we found that they responded to and would understand, and then became invested in the project. Some of the people that joined this group, people like our informatics team, our transformation team, our digital teams, they came along a little bit later, because we soon realised that we couldn't do this just as a bunch of clinicians that wanted to change something in a big system. We needed everybody around the table. And one of the other key people that we got involved quite early on was some academic colleagues from the University of Birmingham. And they've become our critical friends, really, and they're really helpful at keeping us on our toes around our unconscious biases, or when we're sort of like leaning down a certain pathway because we think that that's the right thing to do, whereas they'll pull us back and go, but is it the right thing to do? And that keeps us on track, and that's been really, really helpful. So if you do have those links or able to formulate those relationships, then I would definitely advocate that. We started off really simply at the beginning by asking ourselves, what happened when someone came to Birmingham Women's for an induction? And what we found was lots of things could happen depending on whether it was their first baby, their second baby, whether they had ruptured membranes or not, whether they needed prostaglandins or not, and then obviously there's the potential for then emergency transfers through the system. So the process map really helped us to start to understand what all the possibilities were for somebody that came into our service. So this was right at the beginning. So this isn't now our current process, but this was right back at the very beginning. It showed us that we had lots of different ways of inducing women. They were all different lengths of time, and that becomes then really problematic when you're trying to plan a service, which ultimately is an elective service. So at Birmingham Women's, our induction rate is around 30 to 34%. We have around a 30% section rate, but when you think about that 30% elective work for caesarean section, you've got theatre scheduling, you've got operational management oversight, there's loads of resource put into planning that. And what we found was this other 30% of elective work that we had coming through the service didn't really have any structural oversight or awareness around what was happening with this part of the service. And that also then plays into things like when you're doing your workforce planning, how do you account for that? How do you account for the differences in your inductions from week to week? So we knew we needed to have a real big deep dive into what was going on at various points in this process. What we also realised that we needed to know really early on is, what was it like for a woman to experience this? So we could ask the staff what it was like for them, and we did staff surveys for how they felt caring for women through this process. But it was really important that we asked the service users. So we actually collaborated with our LMNS and the University of Birmingham to do a postal questionnaire. So this was any woman that had an induction in an 8-week period. We did exclude women who'd had a baby admitted to the unit or had a neonatal death or was being induced for a stillbirth. And out of 364 women that we sent the questionnaire to, we had 140 responses back. And this all went through ethical approval. It was set up like a research study, and it's just been published in October in the BJM. That 38% response rate we were quite pleased with for a postal survey, and we looked at both quantitative and qualitative data to help us to understand what it felt like to be in that part of the service and go through that pathway. And actually what we were told from the surveys, obviously there was a large proportion of it that talked about the impact of COVID, because this was in 2021, and what it had felt like for them during COVID to have an induction. But they also raised that they didn't feel they had the right information, and they weren't prepared properly for the process. They didn't know that delays were a possibility, and had they known about that, it would have been a bit easier. They didn't know that it was good to to bring things in to buy the time, like a series on Netflix on their iPad or anything like that. And they also said that they sometimes didn't feel heard during the process, especially when it came to things like analgesia and what options were available. So that's what the women told us. So that was part of our baseline data. So we then moved on to what was happening through our process map and why we were experiencing these delays. So what we looked at, we did a time and demand study, and we looked at how did we book our women. And what we found was that on average, we induce about 6.5 women a day in order to get the number through. So anywhere between sort of 5 and 8 seemed to be the optimum. But we found that there was a large variation in our bookings. Now, a lot of that was to do with we had an induction suite on our labour ward for our high risk inductions that housed 5 women, and then the rest we did on our antenatal ward, which there was never a ceiling, there was never a sort of, it was if there's a bed we can put a lady in it, so there was never sort of any oversight into how many ongoing inductions we were having in the service. And sometimes because of that, the constant peaks and troughs caused bottlenecks in either admission or later on through the pathway. We found that our bed capacity was always maxed out, no matter what we did. And we also realised that we might book the same number of women every day, but because there was different amounts of lengths of induction process, that meant that women were often in a bed more than 24 hours, so that bed wouldn't necessarily be available the next day. So it was easier on Ward 1 to flex those beds, but it then meant that if women were waiting to come to delivery suite, they then blocked those antenatal beds for other potential admissions. You can see there the different lengths of time between nullips and multips. So no surprise, our processes at the time ended up with giving 2 propesses to primary gravid women. And so therefore they potentially could be in a bed for quite a few days. Whereas with our multiparous ladies with ruptured membranes, they were only in that part of the pathway for 6 hours. So what it meant though is that we on average needed to induce 6.5 women a day, and roughly around 5 women a day were ready to be transferred to the delivery suite. So what did that mean for delivery suite? So our demand was 6.5 a day. And actually we were admitting on average 6.5 women a day. So the question is why? So if our demand's the same, we've got the capacity, why is it not working? And the only thing we could come down to was the variation in the length of cycle, and also the variations in booking and bringing in a variety of different numbers of women every day, and that was causing bottlenecks through the system. We got to this point and we were thinking, okay, so why? Why does all this matter? So thinking about the 5 whys that we've just done. So why? What does it matter? So we started to look at if women were delayed, what did that mean for their outcomes? So what we actually found was once women started to wait more than 12 hours for transfer to delivery suite, their risk of poor neonatal or maternal outcome increased. Now, this is not an academic piece of work that the postal survey was an academic piece of work. This was an audit, you know, what I always call back of a fag packet type audit. It's what you do, you know, you look at what you want to look at. So this might not be what happens in your organisation. This was what we found when we did our baseline audit. When we looked at poor outcomes, we looked at things like neonatal and maternal infections. We looked at PPHs, and we also looked at things like analgesia use and mode of birth. What was interesting was that we found the longer that women were delayed for, the more likely they were to end up requesting an epidural and then having the potential complications that came along with an epidural. But then actually, once they waited more than a couple of days, they often, a lot more women end up having no pain relief at all, because they generally tended to establish on the antenatal floor and then come down as urgent admissions and then not have time potentially to have their analgesia of choice. So again, still wasn't ideal. What's interesting is that we found that the longer women were delayed for, the more likely they were to have a caesarean section. Now, that might be because they chose to have a caesarean section, so they decided they didn't want to wait anymore for an ARM and they opted to change their mode of birth and elect to have a caesarean section. There was also an increase in our emergency caesarean sections for things like maternal and neonatal infections. So we took all of this information, and so we thought, right, what do we do with it now? Because it was a lot of information. We also looked at things like how many women we were offering sweeps to, and all the elements of the process map that we showed earlier. But these were the main key points that came out of it. So we took all of that information and we generated the driver diagram. And really, it was about what did we want to achieve? So we wanted to improve the safety and quality for the women and their babies undergoing induction of labour at BW. Now, quality and safety are two very different things. So we come at it from a safety perspective. So as a consultant midwife previously, I might have a lady that maybe had shoulder dystocia on the birth centre. But actually, when you talk to her, she had the best experience because she knew that was a possibility with her risk factors. She chose to birth there, and that was fine. So I'm thinking from a safety perspective, oh no, she's had a poor outcome because she's had her shoulders, but from a quality of experience, she felt she had a really positive birth experience. It was managed well, they were both fine. The shoulder dystocia for her wasn't a bigger deal. So we had to think about where did we want to go first with this project. So we chose the safety arm first. And we're now working more along the quality arm. We did some smaller projects on the quality arm. So we did things like we brought in different options for pain relief. We've brought in a TENS rental service. We've introduced the use of Oromorph during the induction pathway. So it's not just sort of dihydrocodeine and then pethidine and not a lot else. We've looked at the environment of the induction suite and put things like a dining table so women can sit and eat like you would at home. We've changed the lighting, those types of things. We worked with the PPIE group with the University of Birmingham to develop the Top Tips leaflet. And that was, you know, designed by women for women around making sure you bring flip-flops with you, download a series of Netflix onto your iPad, bring a book, bring a knitting, whatever it is, but, you know, pass the time, structure your day. And we then also developed a video tour because actually at the time we'd stopped our hospital tours due to COVID. So we did do some of the quality arm, but our main focus was around reducing delays in the service. So one of the first things that we did, one of the first PDSA cycles that we undertook was changing our length of induction regime for spontaneous rupture membranes. So every lady then, whether you were nullipar or primate, would have 6 hours of prostaglandin. If you were a multiple and could go straight for oxytocin, then you could do that based on the evidence of rates of vaginal birth. And that helped us to standardise this process for these women having this induction for this reason. And what we found was we also made sure that if women chose expectant management, that they were admitted by 18 hours so that they definitely had a prostaglandin by 24 hours. And, you know, rather than coming in at 24 hours and then potentially not getting it till 26, 28, 29 hours later. What we found was that we reduced maternal pyrexia in labour, we reduced the need for neonatal antibiotics, and we reduced our emergency cesarean section rates. What we did find was our instrumental birth rates did increase, and we did see an increase in our postnatal infections, which was a balancing measure that we weren't expecting to see. So then we needed to look, and we went into another QI project around improving antibiotic prophylaxis for operative vaginal births. So this is generally what we find QI does. You make an improvement somewhere, and that leads to another QI project somewhere else, because you identify another issue or another problem that you need to look at. What we found when we people came out from shielding during COVID, our birth to midwife ratio increased temporarily because we still had the redeployment register and things, and it felt better. And so we thought, you know what, it feels like people aren't being as delayed as long. Let's measure it. Let's measure the impact of staffing, because we sometimes get asked to sort these things out. We're asked to do QI projects, but actually thinking about that root cause, thinking about those 5 whys, sometimes the root cause is something that's outside of our influence. So exactly what people were saying before I started the presentation. And what we found actually was when we improved our staffing on delivery suites, we reduced delays by more than 50%. We increased our spontaneous vaginal birth rates, we decreased our instrumental birth rates, and we decreased our caesarean births. This really gets the attention of people like the board. We currently aren't funded to our Birth Rate Plus, but with this, they were looking at how they're going to fund that moving forward. The other things that we did to try and improve flow and capacity is we looked at safe gestational ranges. So when I say a safe gestational range, what we found in the postal survey was that women were told that they had to come in for induction. It was a risk to their baby if they didn't have an induction, and then they'd phone up on the day of induction and we'd say, I'm really sorry, we don't have a bed available, we'll ring you again tomorrow. And women were like, but the doctor's told me my baby's going to die, you know, you're not bringing me in, what's that all about? So we thought, as well as managing expectations, we can also use this to control our flow and try and even out the top end of the system. So we introduced safe gestational ranges based upon national guidance. So for example, a maternal age induction has a gestational range of 39 plus 0 to 39 plus 6. So when you book that induction, you might book a day. So I might say to Kirsty, okay, you're coming in on Wednesday, but your safe range is from Monday to Friday. We may move you within that range. So, and that's safe to do that. So what we found then was we were able to move around and control our flow at the top end. We also employed a flow and capacity coordinator, which originally was off the back of a grant from the Academic Health Science Network, who originally just looked at induction, but then we realised quite quickly that you can't look at flow and capacity just for induction, because if you haven't got any postnatal beds, you can't bring them in the top end of the system anyway. So actually, we needed someone to look at the whole flow and capacity through the service. And I'm really pleased to say that those change ideas were really successful. So these are our admission delays. So when we started the project, about 17% of our women were delayed coming in, and actually in June we had 0% delays. Now we do still have delays, you know, July and August, we've had some women that have been delayed outside of their gestational ranges, but they are fewer and further between now than when they were at the beginning. The other thing that we've found is that actually these two things have helped us to impact positively on women who are delayed more than 24 hours. So we now talk about induction very differently. So whereas before someone had waited 36 hours, nobody really blinked an eye. Now if somebody gets to 24 hours, it's day text, because we know that it can be linked to harm. So we didn't necessarily expect to see this drop as a result of the flow and capacity, but because we know that staffing has such a direct link to this element, but we're pleased that it's having some impact, and that's probably because we're controlling the top end of the system in response to what's going on through the rest of it. We are seeing a gentle increase though in how quickly we are transferring women. So by controlling that top end, we can then transfer women in a more timely way, and we're getting more women round within that target of 6 to 12 hours, which is actually our amber rag status. We do try and get women round within 6, but we want them round by 12. So that's the end of my presentation, and this sort of links with what we were talking about in our breakout room about, you know, reinventing the wheel and not having access to all the other things that other people are doing. And there's so much good work out there, and it's really important that we start sharing that so that people don't spend loads of time doing the same thing over and over again, because actually we're all in the same boat. And thank you for having me here today. And if there's any questions, happy to take.
Thank you, Louisa. We have got some time if people wanted to ask any questions. I realised at the beginning there were some people who were doing work on inductions. Obviously, this is quite a good topic for them. Not sure if they're still on the call, but this is your opportunity if you wanted to ask any questions either directly to Louisa or anybody else. Catherine?
Hello, my name's Kit Robertson. I'm a newly appointed consultant in Oxford. I'm their new QI lead, and with a very particular interest in reducing delay in the process of induction. I'd be really interested to know, and we're finding exactly the same things that what you're seeing in terms of the variation of booking and how we streamline that. Did you take into account your staffing when doing your bookings, or whether the women were primips and multips in terms of what you could book on any given day?
So we don't use either, to be honest. We cap our bookings in the induction bay to 3, so we try and have no more than 8 across the service now, whereas before we could have up to 14. So we try and have 5 on our antenatal ward and 3 in the induction suite a day. We don't look at whether they're nullips or multips, and we don't link it with staffing, because I don't know about anybody else, but our staffing seems to change on an hourly basis at the moment with various things. So yeah, so we just looked at what is our induction rate and how stable has that been, and so therefore how many women did the data tell us that we needed to bring in every day, and we tried, and so it's 6.5. So we went for 8. Again, it was a bit of a stab in the dark. Let's just try it and see how it goes, which sometimes I think is a lot about QI. You just give something a bit of a bash and see how it goes, measure it, and then go back to the start of the cycle again, really, and try again. So yeah, so we haven't looked at it specifically like that.
And if I may, while I just have you, one further question. I see that you used an electronic booking system through Badgernet. We are transitioning to Badgernet, and I am interested to know, so obviously there's a booking request that can go through Badgernet, but is the spreadsheet or the booking system, is that also in Badgernet, or is that done separately on, for example, an Excel spreadsheet?
So we currently use an external system for the actual booking. So we do the booking form. There is a booking system on Badgernet that we're looking at the moment to see whether it will meet our needs. I think what we were trying to do with CleverMed, and we work very closely with them, it's the ability to create lists and be able to clinically prioritise when women are in the system. So now we can get the list for people who are booked for induction. We can get the list of women that are having ongoing induction. One of the challenges we had was when you click the ready for delivery suite button, it doesn't pull through all of the clinical information that maybe you may need, Catherine, to actually make that clinical prioritisation of who's going to come round first. So we've actually done a separate spreadsheet that's got a clock embedded in it, so it actually has a timer to show how long people have been waiting, as well as all of their clinical information, so that prioritisation can be done more accurately and safely.
And is that in, do you mind me asking what software platform you're using for that?
Excel.
Excel, perfect. Thank you, that's great.
More than happy to share,
definitely.
a blank one. It's not my piece of work. I'm very not technically proficient.
Super, thank you so much.
You've also got a comment here from Alice to say, are you happy to share any SOPL guidelines that you've used?
Yeah. So a lot of the stuff that we have used and done is on the Futures platform already. Lindsay's put that up, but I'm more than happy to share with Lindsay the waiting for delivery suite Excel spreadsheet, because that's quite a new piece of the puzzle. Happy to share our current guideline if that would be helpful.
Thank you. And then we've got a question from Lauren.
Hello, I've got a few questions actually, if that's okay. Louisa, that was a really good presentation. Thank you for that. I'm the induction of labour leader at Cardiff and Vale, so I'm keen to really keep close contact with you if possible so that you can help us. I was just wondering, so a couple of questions in terms of your process. Have you found, so do you use a mechanical method of induction?
Yeah, we use Dial-A-Pan.
You do use Dial-A-Pan, same, so we do in Cardiff. And then outpatients, have you found that that's made, if you kind of done anything with outpatient induction?
So we've always had an outpatient process, but only for post-dates, low risk, which is a pro-peth. They go home for 24 hours and come back. it's probably no surprise, we don't have many post dates inductions anymore. Gone are the days
Okay.
where everybody was post dates and that was the only reason that they were induced. So yeah, so we find that we don't get that many.
Yeah.
So it hasn't really had a big impact
Fine.
onto it.
Okay. And then for things like low PAPA, raised BMI, do you have any sort of set guidance on whether you offer induction for that or not? Have you done anything about any work around kind of what you were offering induction for and whether you've changed the kind of the boundaries for that?
It's
Not
not been a
necessarily the gestational range, but just kind of what you're
Yeah,
offering
it's not
induction
been a
for.
focal point. We've just gone by national guidance. So low PAPA in isolation, we wouldn't offer induction
No.
for, but it will depend on the growth of
Yeah.
baby, and that would indicate induction or not. BMI, again, we just sort of follow. We don't induce. Once we get to BMIs of 50s, then yes, we do. But we just try and follow the national guidance as far as possible.
Yeah. Okay, perfect. And then with your, sorry, I know everyone else is trying to get in. Audit data, how did you have like a certain person that did that, or was it kind of a team of you collecting that data, and how did you collect it?
So for the baseline data, we had someone from our transformation team that was doing their silver QI qualification or course, whatever you want to call it. They were a midwife. They're now actually one of our flow and capacity midwives. And so she did the baseline data audit, which was really time consuming because it was every induction for an entire month.
Yeah.
And we didn't know what we needed to measure, so we measured everything.
Yeah.
And I mean, like that initial presentation is about 60 slides with all that information on it. So yes, we did have that investment early on. The audits that we've done subsequently have been more local, but they've been able to be more succinct into what are we measuring, what change idea have we done, what are we measuring it against, and how are we going to measure that improvement. And obviously, once we got that set, that's the same that we do every time we do an audit, so it's less time consuming.
Brilliant. And then if you could share your email just so I can speak to you outside of this meeting, that'd be lovely.
It's just my name. It's just my name. I'll put it in the chat. It's just my name
Lovely.
at nhs.net.
Lovely. Thank you, Louisa.
Thank you. We got a question from Liana as well. Oh, I think you're on mute still. You just take yourself off mute.
Sorry about
Thank
that.
you.
So I'm very grateful to be here today. Now, I'm one of the specialty doctors in a very, very small hospital, maybe the smallest in the UK. I work in Wales in Aberystwyth. It is very interesting what you all said, Louisa. I loved it, but I have two questions. Number one, I saw in, I think, your second slide, the idea of a waiting list for ARM. Could you please elaborate a little bit on that? And the second question that I need to ask you, it is interesting that you say that the number of inductions of labor for post dates has diminished. We still have them quite a lot. Why do you think they diminished with you? Is it a little bit more medicalization? Now, what we're doing here in Aberystwyth, we are fighting like hell. You don't know how our midwives fight to keep everybody normal, within the normal pathway. So we still have the inductions for post dates. These are my two questions for now, but I would cherish every kind of information you could share with us or with me personally in the
So the waiting list, I suppose, is another way of putting our prioritization list. So when women are ready for delivery suite, they go on to that list. If they can't come straight down. Now, every now and then, we have a few weeks where as they go on, they get taken back off, and the band sevens are really quite excited when that happens. They go, we have to go on the list so I can take her straight off. Just because then we can audit that data, because without doing that, you can't then audit the times that you can move them really well. But if we aren't able to move them straight to our labour ward because of other acuity, then they sit on that. So it enables us to see that list. What we had previously was a paper list. So if I was on the antenatal ward, I would ring down to the induction suite and say, Lindsay's ready for delivery suite from this date and time. She's for an ARM or she's for oxytocin. And then that piece of paper would sit by the induction desk, until the ward round, and then it would be reviewed. Whereas now we have where we have our centralised monitoring in our handover room, the screen next to it has the waiting for delivery suite list on it. So actually it's reviewed constantly, and you can constantly see if you're making it. And because it's got an embedded clock in it, it helps us to rag rate it. So if it's less than 6 hours, they're green, 6 to 12 is amber, more than 12 is red.
This is how you deviate from the guideline because of lack of space, physical space, lack of physical staff and things
So
like
it
that.
can
because
be, it can be space, it can be staff,
Yeah.
it can just be acuity of what's walking through the front door, the
Yeah.
natural fluctuation. It can be a variety of things, or it can be all of them at the same time, which, you know, it often happens. In answer to your second question, I don't know if our post dates has reduced. It's just never been one of our highest reasons for induction. So I've only been here for 4 years. We did some very early audits right back when I first started in 2019, which again didn't show post dates as a high reason for induction. Our reasons for induction are often RFM, growth issues, diabetes. They tend to be our higher indications for induction. Post dates comes actually quite a way down. Now that might be the different clientele, the inner city, the diversity. You know, it could be a variety of different reasons why, but that's what we have that comes through our front door.
Thank you. Thank you very much.
Annie, you've got a question?
Yeah, getting away from kind of a induction of labour specifically, the bit of a QI project where you're trying to understand a problem can not feel like you're getting anywhere, in my experience anyway. Can, you know, be sort of one of the trickiest parts of a QI project. So sort of for the people who are here who may not have much experience of doing QI, how long would you say it took from when you sort of first said, okay, we have a problem, to when you say, okay, we think we now understand what the problem is? And how did it feel going through that process? And do you have any tips for people who have identified a problem, but they don't really know yet what the problem might be? Not specifically with induction, but just,
yeah,
we have a problem.
It probably took us a year to really understand where we needed to focus, because you just sometimes want to stop the world from turning, don't you, for 5 minutes just to try and get an idea of what actually is going on, but that doesn't happen. And then you are under pressure from other people to say, what are you doing, what are you doing, what are you doing, where's the output, where's the output? And I think that had been a mistake that we'd made previously, in that we'd go, okay, let's try this, so that it looked like we were doing something, but then actually it didn't work, or it didn't have a sustainable change, you know, that carried on, because of the work we did around understanding where our problems were. So the process mapping of the pathway, the baseline data, which, like I said, we measured everything and we haven't used about 60-70% of it, you know. And then the putting it into a driver diagram, getting the MNVP and the PPIE groups involved, because actually what's it like, and getting that woman's story involved. We did staff surveys. Staff used to hate looking after women for induction because they kept hating having to apologise all the time. So then you've got that cultural issue around women staff not really wanting to do this as part of their day job. So there was loads of stuff that we looked at. So yeah, it was about a year. And I mean, we've only really scratched the surface by looking at delays. You know, we're now doing a quality arm, we're looking at informed consent, we're looking at information, antenatal classes have been launched, and all sorts of other things around the quality arm of the project. But to get some good direction that you could then say, okay, can we measure it? Because I think that's part of the problem as well sometimes with QI. It's how do we measure it? And then what do we do with the output of that? Especially then what are we going to do with the balancing measures? Because if you find then other problems, where's the resource? So with our changing our SHROM regime, we had the issue of higher instrumental bursts, that then we realised we weren't doing the antibiotics as well as we could. So that then led into something else, which, so again, it's thinking about your rotational trainees are quite good at getting these little mini QI projects involved in the big QI project. So sometimes sort of trying to do a pocket size one first, because otherwise it can seem so vast that you just haven't got a clue where to start. And I think it's been the little wins that's helped keep the group engaged. So we used to run it, I've said this to Lindsay before, we used to do it when I first started, the only time we could do it was a Friday afternoon between 2 and 4. And it got nicknamed as double maths because it was like a really heavy meeting on a Friday afternoon. And everyone's like, oh my God, it's double maths today, because it was really hard work at the beginning. It's now on a Thursday morning, you'd be pleased to know, but it's still nicknamed as double maths, and people will talk about it. Even our sort of medical director talks about how's double maths going. So that actually the team created their own identity, and then they own it. I mean, I'm less involved now in my new role. So, our antenatal ward manager, our one sister, she now chairs the group and leads the group. So, so it's interesting.
That's so helpful. Thank you so much. I think when you get these kind of presentations that look so amazing, it can feel like, oh, well, we just have to go and do this. So to kind of hear a bit about that journey and that kind of process and how long it takes is really, really helpful. Thank you.
You've got a question in the chat from Lauren about how often your group meets.
It's every 3 weeks. We felt that every 2 weeks was too frequent, but every month sometimes you got a bit lazy in your actions. So we went down the middle. Whether that's right or not, I don't know. Sometimes we have extra people, sometimes we have less. We used to, when we first started, have like an operational arm, an informatics arm, a clinical arm, and sometimes we rotated it so that people didn't have to come to all of them. And it meant that people had a bit more time. So we do tweak it slightly depending on what we're trying to do. So when we were doing the baseline data, for example, it was a lot around informatics data. We used to have meetings just about BadgerNet, for example, about how do we use the induction labour booking form, and making videos of teaching staff to use the booking form and things like that. So it's all those little things.
Thank you. And Lindsay's got a question. I think there's an additional question in the chat for you.
Not so much a question, but I suppose building on what Annie said about the journey, Louisa's been sharing their good work in Birmingham for the best part of 18 months now through some of our Midlands regional work that's happening. So it's just really great to know it's still going, and hopefully gives everybody that kind of resilience that it absolutely doesn't happen overnight, and it is a keep chipping away at the small bit. So just thanks, Louisa. I've heard it a few times now, but every time I hear it again, there's more and new bits you've built on. So it's great to hear about it.
Thank you, everybody. So if there's any other further questions, obviously pop it in the chat, and Louisa can have a look at those and respond to those individually if you've got those. But thank you for everybody for joining today, and hopefully you've had something useful out of today, whether you've been able to reflect on your own setup, your own experiences, or the projects that you're working on, or been able to take anything that's transferable over to the work, then that's great. So as I said at the beginning, it is a series of events, so we will be planning something for January time after the sort of winter pressures and Christmas buzz. So we'll send information out about our upcoming events as well. We've got our futures platform, which we'll pop a link into the chat. A couple of people had joined while we were on here today, so any information or linking up with anybody, any discussions you can start in there with any work that you want to reach out for people. And then we've also got the feedback as well. So if you have a moment, I would appreciate if you can then fill out your feedback form, and that'll also give you a certificate for today so that you can use this for some CPD hours and learning as well. So that's in there for you, so you can take a few minutes to do that, and then take 10 minutes back for yourself today to carry on doing what you need to do with your work. All right. So thank you, everybody.